Hello friends, I am Dr. Bhagyesh. I am a emergency physician where as we say that in emergency room and in ICU when we are treating patients we get problems like patients getting COVID or not. So let's start with a simple conversation that if you guys have seen a patient in emergency room or you have a call from your emergency that sir there is a patient who has come to you and we want you to see what are the questions happen for us. Half of the time what happens is we always ask them on phone that is he having fever, is he having breathlessness, is he having cough, is he having sore throat. Considering all these questions, we take a call that, okay, I need to go and see the patient or I need to refer him. But don't you think that these questions are something which we ask for any patient who is being called for emergency appointment? Being ICU specialist, being emergency specialist, this is something which we ask for any patient that, okay, what are the vitals, what are the SpO2, what are the complaints of the patient? So what has changed in emergency room since the COVID-19 came into picture in India? So that's my topic for today. That what's our ER life, or does our ER life has changed after this COVID-19 scenario? Let's see how. I'll go through few slides, very simple ones, but just to give you an idea that how we have evolved over the emergency room management in COVID-19 patients. Uh, let's begin with the first slide. So I'll start with a triage of patient with suspected COVID-19 infection in no or limited community transmission. I'm sure all of us are not in red zone for now. So for someone who is not in red zone, what are the ways of triaging a patient who comes with suspected COVID infection? Uh, Definitely, the identification signs to be checked in the flu corner, which is a specified corner at the entrance of your hospital setup or the clinic setup, which is away, and there are healthcare workers with proper PPE guidelines being stationed, and they will ask these questions: that does the patient has a fever, does he have any of one sign or symptoms like cough, shortness of breath, sore throat, or anything like that. If there is no to these questions, then he'll go with the routine emergency room triage, and there will be assessment by the emergency room doctor, and then he'll call to you and he'll start a primary management and all. But yes, if there are yes signs in this questionnaire like fever, history of respiratory disease, or any cough, shortness of breath which is a recent onset, or worsening of these symptoms, first and foremost thing is you put a medical mask on the patient. So ask the patient to have a mask on his face, and then you go for other histories like, does he have any travel history? Does he or any other family member of his who is living with him has a travel history? Does he have a direct exposure history? He has been to a meeting, he has been to a function where the patient has been exposed to a person who later on found to be COVID positive. If any of this history is there, then definitely he needs an isolation area. So you'll have to separate this person from rest of your patients and ask him to go to a single person room or an isolation room if you have a facility, and ensure that your healthcare providers or your colleagues or your healthcare workers are providing proper standard contact and droplet precautions with level 3 PPE if they are going to handle the person. Again, the room or the area where this patient moves will be having minimal movement of the healthcare workers with all the necessary things stationed inside. So there will be a monitoring device, there will be oxygen providing device and all other things, but there will be minimum movement of healthcare workers. Suppose this was no, the patient doesn't have travel history or direct exposure history, then what you can do is you can continue with your triage, but give him a warning, and based on your local state-based guidelines, you can suggest him an OPD-based COVID-19 testing, or you can shift them to a COVID care center where a basic management can be done. And if there is not allowing from the government side that you cannot treat this patient in your private clinic or setup, then you can shift them to the government setup, which admits such suspected patients and test them. The first and foremost thing in all these questions and the management or the flowchart is that when the patient comes to you to emergency room, he is having two kind of stress. One stress is due to the disease itself, and other stress is actually due to the panic. So you need to address both. So be calm, composed, clear on what you guide them, as well as make them understand that this is your limitation to do such way of triage, and you are doing everything to help them. So that is also one of the important thing which we most of the time forget, and sometimes even our healthcare workers are in stress once they hear that the patient has fever or breathlessness. So this is something which we have to keep in mind. Now, keeping in mind the history of fever or breathlessness or cough or sore throat, there is something which we have to keep in mind for elderly patient again, that in elderly patient you may not see a fever, but definitely there is a new onset cough or breathlessness or any other respiratory symptoms. Elderly people with comorbidities like diabetes, hypertension, or any other kidney disease are always a high risk patient. Now, coming to the contact exposure history, a contact will be the person who has been involved in 14 days within period of 14 days after onset of symptom, like providing direct care of patient with COVID-19 in the family or around the family without using proper PPEs, staying in very same close environment for longer time against a COVID-19 patient in the vicinity, or traveling with a COVID-19 patient in any way. So far, this was a triage plan for no or limited community transmission. Now coming to next slide. Yes. Now coming to next slide, I'll enlarge it for you. Now, as you see in this slide, this is showing you the recommendation based on case severity and risk factors, irrespective of transmission scenario. So whether you are getting a local community transmission or no community transmission, what will happen is a case severity of mild or moderate without much risk factors, where the patient has simple cough and mild breathlessness. All you have to do is patient should be instructed to self-isolate and contact on any helpline or any telemedicine facility which government or any private hospitals are providing, and do the testing and stay in touch with the medical healthcare workers. Self-isolation would be again something which they have to maintain till they get symptomatically better or till the healthcare facility allows them to go out of isolation. Now, when we say moderate risk factors or severe or critical patients, these are the patients who come to you with extreme breathlessness, symptomatic hypoxia, or drowsiness, or any other comorbidities worsening, like a patient on kidney disease or dialysis, worsening with increasing creatinine or increasing breathlessness, severe acidosis on ABG with hypoxia less than 100 PO2. All these patients will have to get emergency admission hospitalization in a proper isolation or ICU facility. All these patients who have risk factors like age over 60 years, hypertension, diabetes, cardiac disease, COPD, immunocompromised condition, all this should be tested. And if again required, you can do a repeat testing if symptoms are not settled. Now, going to the severity, as we know that critical patients are very few percentage in number, but definitely they require to be identified in the early stage when it is mild and which can be managed at home. So the ties from ER facility is something very much important. Now coming to the next slide. Now screening and triage in such a facility where you have this flu corner, where you have a COVID treating facility or COVID treating isolation or ICU, or where you are running a COVID care center. What we have to see is we have to do isolation, which is home isolation or in a isolation center or in a hospital, or at the same time, what we have to see is that this isolation is followed by a proper triage where the treatment protocols can be followed in time. So, taking one scenario, a mildly ill patient with concerns about COVID-19, he will call a hotline or a telemedicine center and he'll be asked to go for a private laboratory setup or a government center which is allowed to do a testing. Or if your facility is allowing or your government is allowing a home-based testing in a OPD setup, that can also be done rather than bringing the patient to the healthcare system itself. Same way, a severely ill patient who is concerned about getting COVID or he is suspecting that he is having COVID, there he will call a care center or a hotline again or a government setup. Then we'll send an ambulance which is equipped for treating a COVID patient with proper PPE followed by all the health care workers accompanying the person in the ambulance, and he'll be transported to a center which can give a proper isolation ICU care. So this will be done on a priority basis, and the triage center in this setup will be a telemedicine center along with the ambulance itself, where on the way they will decide that where the patient needs to be sent. Coming to another slide. Now we'll go to a slide where I will discuss about a triage of patient with suspected COVID-19 infection in a widespread community transmission. We are not seeing community transmission in all states of India, but all of us know that there are many patients in the community who deny history of any direct exposure to a COVID-19 patient, and they still come positive with all ongoing symptoms, or maybe asymptomatic, and suddenly you find in one area that there are 5 patients sampled and all 5 are positive. So such a case, which is happening in most of the states now, Gujarat started with low number, now Ahmedabad is picking any other cities. So all this, when happens, then the triage becomes even more simpler, where we ask for fever, cough, shortness of breath. No, you go to your management plan for any other simple case patients. But if it is yes, whether the breathlessness was due to cardiac or heart failure or any other thing, but here in this scenario, we'll consider this patient a suspect and ask him to wear a mask, separate him, isolate him. Then the healthcare worker who is fully equipped with proper PPE care will go to that patient, will start treating him or her, and meanwhile will send the report for COVID-19. Now, again, keep in mind that elderly patient may not give you all the symptoms or signs positive. So that is something which we have to keep in mind while treating such patients. But here in this scenario, the triage is very simple. Symptoms of breathlessness, symptoms of cough, symptoms of fever, consider COVID positive unless proven otherwise. So all patients with these symptoms will be isolated and treated as COVID positive in a proper isolation area. If not available in your setup, you can refer to the government setup or any private setup which admits such patient. Let them identify that whether the patient is COVID negative or positive, and then you can bring them back if it is COVID negative and treat as per the required organ supports. Now coming to the last slide. After that, we will take questions and you can put your questions in chat also. This is a simple flowchart given by CDC again. But here, what they started with was any past history of travel or close contact. Then the patient has symptom of fever and respiratory illness. Isolate them, check clinical status, and you divide accordingly for home isolation or a COVID care center or a COVID care ICU. So this is a simpler side, combining all the protocols, triage in a non-infected area or less infected area, and triage in infected area. This is a common protocol. Now, one thing I want you to understand is that now all of the WHO and all world level authorities have agreed that you can look at this fifth point: designate hospitals to receive COVID-19 patient and prepare to mobilize acute and ICU surge capacity. Even our ICMR has agreed that we'll have to have a three-layer hospitals where the top level is ICU level care where ventilated patients are care. Middle level is mild or moderate cases but positive requiring observation. And third level is a simple isolation or quarantine area. So these three levels, everyone has agreed because we want to cluster them in one center so that there is no or less chance of community transmission happening and we can do a proper management of such cases. This completes my scenario of how your ER life has changed in this COVID situation.